on the level of the fetal kidney and the perfusion of the fetal kidney. It will result in the lower production of
that's why we use it in
that's the reason why we use it as a therapeutic procedure if we have a polyhydramnios. Actually, indomethacin have the direct influence to the reduce of urinary fetal urinary production. The consequence and the result will be the reduce in amniotic fluid. But the completely different mechanism concerning the antiprostaglandin mechanism is related to the indomethacin as a tocolytic therapy, because indomethacin is very effective in to stop the contractions. If you have the preterm contraction, it will be sometimes very useful to administrate the suppositoria or the tablets of indomethacin just to stop contractions in very quickly, and then you can continue actually the tocolytic therapy with some other sort of tocolysis. But the cadmium between 32 and 34. Next one, please. I've told you that the malformation of urinary tract and the obstructions on the level of the uropoietic system are closely related with the development of polyhydramnios and with the decrease in the amniotic fluid volume. Primarily, and if we follow the system of the early pregnancy towards the late pregnancy, the bilateral renal metastasis, which will be recognizable very early in pregnancy, it will be impossible to recognize the normal kidneys on the ultrasound scan, and these kidneys will be non-recognizable because they are not developed, but also because the antiglomulus is associated in this case, and the visualization is of a very low quality. It is not it isn't possible to perform the detailed evaluation of anatomy in this type of malformation because it is always associated, if it is bilateral, it is always associated with a severe oligohydramnios or complete anhydramnios. If we are talking about bilateral renal metastasis, if it is unilateral, then the one normal kidney will function completely normal and the physiology will be normal, so the result will be also the normal amount of the amniotic fluid. The polycystic kidneys, it is also the sort of the malformation which result actually in afunctional kidney, in completely decreased function of kidneys and uropoietic systems. The result will be oligo or complete anhydramnios. The ultrasound diagnosis it's not so difficult because it is very easy to recognize very large and hyperphotic kidneys inside of the fetal trunk and the severe reduce of amniotic fluid associated with the empty urinary bladder, which is actually impossible to visualize. If we have bilateral disorder in development of kidneys, this type of development and disorder is so-called dysplastic or multicystic kidneys. If this process will affect the both of kidneys, it means if we have bilateral multicystic kidneys, then the urinary production is decreased in the both of kidneys, and the result will be also oligohydramnios and the severe reduce in amniotic fluid volume. Then we have the so-called urinary obstructions.
What is the difference between polycystic and multicystic?
It's not time just now, but just a brief explanation. It is a dysplastic disorder of kidney where we have the kidneys with large cysts, large cystic structures, clearly separated with septa, and it is very easy to recognize these large cysts and the kidney, which is completely different compared to the normal one. The polycystic kidney, this term does include also 1 million of small cysts, which are very often under the resolution ability of the machine. And that's the reason why this kidney is hyperechoic, and it is very similar in ultrasound appearance to, for example, molar pregnancy. 1 million of small cysts, actually, which are under the resolution of the machine, will result in large hyperechoic and white kidneys, comparing to this also very large kidneys, but in this case the cysts are large, few centimeters in diameter, and clearly recognizable by ultrasound examination. The urinary obstructions, primarily because of bilateral ureteral obstructions or because of the posterior urethral veil, it is actually the venting mechanism which can result in retention of urine and dilatation of urinary bladder and retrograde dilatation of one or both ureters, will actually result in retention of urine, and the derivation of urine is decreased. It doesn't mean that the production is abnormal. The production is abnormal, but the derivation is completely compromised. We have the retention of the urine within the uroplastic system. The consequence will be the oligohydramnios and severe reduction in amniotic fluid volume. The same is actually with bilateral ureteral cells. It is very rare condition, but sometimes it is very useful to keep it on mind because it will result with sometimes with bilateral, but most commonly with unilateral retention. In this case, it is not related with the abnormal amount of amniotic fluid because the production and derivation from the other healthy side is normal, but on this affected side where the ureterocella is the reason for the urinary stop on the level of on the place where actually the ureter is entering the trigonal part of the urinary bladder, it will be the reason for the severe retention and consecutive hydronephrosis on this opposite side. Sometimes also we will have the secondary or so-called compressive urinary obstruction. It means that the complete urinary system is normal, but some other process, particularly some tumors inside of the fetal abdomen, can press the ureters or bladder or can press the lower part of the pelvic, and just to be the reason for the abnormal possibility for urinary derivation and amniotic fluid volume, or if we have the high-risk fetus, which is, and the pregnancy which is associated with preterm contractions, then the preterm contractions and the reduced amount of amniotic fluid will be actually the reason for the different type of fetal movements and fetal breathing movements, which could be included in this examination, in this screening program. Actually, it is the part of the fetal biophysical profile, which will be the main ultrasonic tool associated with Doppler measurements to estimate the fetal well-being, and just the very important ultrasonic parameter for the prognosis and for the final decision when we do have to interrupt this pregnancy because of the fetal well-being. Placenta location and the confirmation of the placenta location during the third trimester. Early detection of the fetal hypoxia, it is closely related to the Doppler measurements, and we will talk about it later during the lectures about the Doppler measurements and changes in the hemodynamics related to the acute and chronic fetal hypoxic status. And Doppler measurements but only in a high-risk group of the patients. If don't forget that we are talking about the screening programs. The screening programs, it means actually the implementation of all of these examinations and all of this complete pattern of the examination in a low-risk and non-selected population. It is not very useful to perform the Doppler measurements in the low-risk population because the cost-effectiveness analysis is not appropriate. And Doppler measurements actually should be the useful ultrasound tool, but only in a high-risk group of patients. Next one, please. Well, some examples. It is the normal embryonic anatomy. Using the transvaginal probe, it is clear to make a distinction between the head, trunks, extremities, and the sac. It is the coronal section of this embryo, but on the opposite side we have the transvaginal sagittal imaging of the fetus, medial sagittal, and which are the details which you can recognize here. As the first one, which will appear earlier, is a problem of the it's not the limb. The limb is maybe this one or maybe this one, the part of the limb. I'm not sure. It is. I think that this one is the transverse section of the umbilical cord, not the limb, because we are in a sagittal section. And here it is maybe a part of the limb. It is actually the optimal crown rump length because we can recognize the end of the spine here, the neural tube, and the top of the head. It is the very good example for the accurate and correct crown rump measurement. But in this transvaginal sagittal scan, you can recognize two abnormalities actually. Are you sure that this is neural translucent?
No, if you see the amnion, then...
How can you be sure that it is not the amnion?
But I think it's the...
Stop here. Let's go back to the anterior abdominal wall. Yes. Because regarding the embryological development, yes, the physiological herniation will be the morphological finding which we can recognize earlier than Newham translucency. Definitely, yes.
First,
yes, the umbilical no, it is not a recommendation to use the term umbilical herniation because it does actually it has the indication to malformation. But we have to talk about something which is normal, which we have to expect during the first trimester. It is the physiological midgut herniation. Physiological midgut herniation actually it means this herniation in the basement of the umbilical cord, the insertion place of the umbilical cord on the anterior abdominal wall. The herniation of the bowel in this part of the umbilical cord, very close to the abdominal wall, it is a normal finding during the first trimester and should have disappeared approximately between the end of the 11 and 13 weeks, during the 12 and 13 weeks. But the gestational age, when we will recognize the physiological midgut herniation, is approximately about 8 or 9 weeks. And we will follow this finding, and it should disappear during the 12 and 13 weeks. A week or two later, during the 10 or 11, 12, and in the window between 10 and 14 weeks, we will try to recognize the Newham translucency. If we are talking about the physiological herniation, we can find the physiological herniation with the 7 or 8 weeks. And this herniation could disappear during the next week or two. And when we get the patient for the 10 to 14 screening program, then we will not find this herniation. But in this window between 10 and 14, we have to measure the nuclear translucency, the amount of the free fluid in nuclear region. It is very important to perform this distinction between amnion and skin, and then to perform the measurement. It is not the topic of this lesson, of this lecture, and we will repeat it when we will talk about this sonar biology and first trimester markers. It means the dilatation of the umbilical vein or urachal cyst. It is very different to make the distinction by ultrasonography. Actually, these are the pathophysiological differentiation and classification, but it is very important to make a clear distinction in a differential diagnosis comparing with sometimes with gastroschisis or the small omphalocele, because some of the umbilical cysts which are large and very close to the abdominal insertion of the umbilical cord will limit maybe the finding of omphalocele. It is important to perform the clear distinction. All of these diagnostic criteria we will summarize and we will talk about the defects of anterior abdominal wall. If we have a finding of umbilical cord cyst during the first trimester of pregnancy, it has to be accepted as a soft marker of chromosomal disorders. This cyst will appear during the second trimester and with the normal development of the fetus and the umbilical cord. But if we have a finding actually of umbilical cyst during the first 14 weeks, then we have to accept it in this cumulative index and this cumulative estimation of risk for development of chromosomal disorder. Next one, please. It is a picture from textbook, but it is a very rare condition, and that's the reason why it's depicted here. It is a 5-vessel cord. If we are talking about the increased number of vessels in umbilical cord, more than 80% will be one vein and increased number of arteries. In this case, we have 2 umbilical veins and 3 umbilical arteries. Very rare condition which could be associated with specific malformation in thin pregnancy. It is the case of actually Siamese twins, conjoined twins, of thoraco-omphalous twins. It means that these twins are connected together in the region of anterior wall of chest and anterior wall of the abdomen. And with color technology we can recognize this connection of umbilical cords also, and the transverse section actually is this 5-vessel cord, which is the cord of the same cord for these two twins, 2 veins and 3 arteries. It means actually that it is the combination of 2 umbilical cords, one normal and one with single umbilical artery. But the fusion of this artery, because of the conjoined twins, the fusion of these umbilical cords will result in this bizarre combination and very rare case. Next one. Umbilical cord entanglement, a specific malformation for monoamniotic twins, very rarely in monochorionic diamniotic, but primarily in monoamniotic, when we have the close insertion of umbilical cords on the chorionic plate of placenta,